Okay. Hi, I'm Lori Bishop. I am a nurse by background, and I'm just really privileged to be here on behalf of NHPCO, the National Hospice and Palliative Care Organization. I am their VP for Palliative and Advanced Care, so I guess that's how I got this gig, but I'm really excited to be here. There's a couple things I wanted to share about what we're focused on at NHPCO and also in collaboration with many of the other national organizations that we work with. There's three approaches that we're going to talk about here. One is payment and delivery models. Another is new legislation. And finally, I'm going to share with you one of the independent or innovative models that NHPCO is going to develop for access and equity to help our members do a better job. So first of all, I wanted to talk about the mythical unicorn we're all waiting to drop out of the sky, and that's the serious illness alternative payment model. It's for Medicare beneficiaries. It will be a limited scale demonstration project, and we don't know yet what it will look like. But our colleagues at CTAC and AHPM put forth some beautiful models. They were told to collaborate on those models when they went to the Physician Technical Advisory Committee, and they got approved to move through, and we're waiting. And we're waiting. We know that part of what we're going to look at in that model, at least the consistent themes in that model, were interdisciplinary care, whole person and family-centered care, and 24-hour access. And I was just talking with colleagues at lunch today about how essential that 24-hour access is. And again, those are key components, as we all know, of a model that's worked really well for 40 years, and that happens to be the hospice model of care. And I always thought, why isn't all of healthcare based on this model? I think I might have even said that in one of these other NASM meetings. And I'm glad that I'm living to see it start to move upstream. I think that is what we all want. None of us wants to be seen as a patient. We want to be seen as a whole person, and we want our family included in that care, whatever we define as family. And so I think this is a great thing. We're waiting for it to happen. We don't know when it's going to happen, maybe in April. And we don't know who all is going to be included. But I think the key here for equity and access is that multiple types of organizations should be allowed to participate. So I'm hopeful for that, so that we make sure that we do get representation of all different groups and populations in that demonstration, and not just one standard demographic. So stay tuned on that one. Now I'm going to walk through a few of the legislative activities that we're focused on at NHPCO for this year. And again, many of our colleagues at a national level are also supportive of these legislative activities. One is the Rural Access to Hospice Act. And it's a bit of a misnomer because it's not just rural health centers. It's also federally qualified health centers, also known as community health centers, that are affected by this. And it's a little known issue that it's a disincentive for the physicians in those entities, in those centers, to actually refer their patients to hospice, because they then can no longer get reimbursed for the care they provide for their patient. Because they're getting a whole payment, and that payment does not include hospice care. So what we're trying to say is we don't want people to have to give up their primary care provider, and we would not expect them to. This is a no-brainer. Everybody agrees with it. It has bipartisan support. The issue is it always gets tacked on to something else that doesn't have bipartisan support. And so we are hopeful that we are going to get this pushed through this year. CMS has already provided some technical advice on this. It's going to be introduced in the next week, so fingers crossed. Please support it. Please tell your legislature to support it. It is really a no-brainer. Everybody wins, and we get greater access to care for people who need it in those areas. The next one I'm going to talk about is PCHETA. So that is another great bill with bipartisan support. And this is from a workforce issue. I think we've all agreed in here there's a workforce shortage. We've recognized that there's not going to be enough of the specialty to provide this care. There might not be enough primary care. We need to add the community health workers. You know, this bill really helps for education, and it's very comprehensive. It also supports some levels of research. I think what really strikes me is some of the data associated with this, and that is that estimates show that there will be no more than a 1% growth in palliative care and hospice physician workforce over the next 20 years. 1% growth. Meanwhile, there will be the number of people eligible for palliative care will increase by over 20%. So that's a huge disconnect. So obviously, it's going to take a village to get this done, and we need to educate the village. And I think we're all capable of providing excellent palliative care, but we need the training to do that. So again, this is another big bipartisan support. It's passed in the House last year. And the additional to the original co-sponsors of Representative Engel and Reed, both of New York, the Energy and Commerce Chairman Pallone from New Jersey and the ranking member Walden have also co-sponsored. So it was reintroduced this January. We expect it to pass in 116th Congress. Again, another one you might want to go out there and say, hey, please support this. Good legislation. The next thing I wanted to talk about was some of the proposals for NHPCO this year, and they might surprise some of you. As you know, we do have a new CEO, Ido Bannock, who came to us from CMS, and he understands and has a passion for this longitudinal care for the seriously ill. So we are really looking at how can we eliminate the barriers to this hospice model of care, so that people with serious illness get access to person-centered interdisciplinary care in a more timely manner. And some of that might be structural reform of the hospice Medicare benefit. And so I just want you to know that we are really looking at that. We know that a couple of the barriers, and it's been proven now for over 40 years, is that we cannot prognosticate to 6 months or less to live. I don't know if that comes to a shock to any of you, but we've got 40 years to prove it in the hospice benefit, that we can't do it. So why do we have that still as a marker? Also, there's a great demonstration with Medicare Care Choices model about concurrent care, and we would like to see that be approved and allowed for all patients. Now, the problem with this might be, how do you pay for it? And maybe the thought is that you actually provide a tier of care that's palliative care further upstream from hospice care within a continuum of care, and that's how you pay for it. So you might get the intensive hospice care for a shorter period of time overall, but you get it when you need it, would be the point of that. And we can put some guardrails around that. And I think that just makes more sense. So I just want you to know that's part of where we're thinking. And if anybody here wants to join us on that journey, we welcome your input in that. We also know that we need to really define what community-based palliative care is and what the guardrails are around that. So we all talk about palliative care as if we know what we're talking about, but it seems like everybody creates a different definition. There's different expectations of what the basic treatments or standards you're going to provide are. We do have beautiful NCP guidelines out there. Some people are following them and some are not. So I think that's another point of contention. And I get the calls from consumers at NHPCO, from our Solutions Center, from consumers who are saying, I'm trying to get palliative care. Your website tells me this is what it is. Where can I find that? And I can point them to some providers, and then they say, yeah, I went to them, and here's what they said. So it's really troubling to me, and I hope we're getting to a tipping point where we can, you do have to be careful what you wish for. I've joked about that for years with palliative care, because it's like, well, the good news is you can be very innovative in palliative care. The bad news is there's not a lot that's paid for. And so, we got to be careful and thoughtful about the regulation. And again, I think it takes all of us, including seriously ill individuals and their families, to be at the table to form this legislation and figure out what those basics are. We've got a great example out in California with the implementation of SB 1004 that has some lovely bill language on what the basic expectations are for the Medi-Cal population. There's no reason to recreate the wheel. I think it's a great starting point right there. And they have a year of learning under their belt too, so we could see how is that going? What are you learning? What do you wish you would have done differently? So there's lots of opportunity out there. And then, how do we expand the access to services? And again, we're going to focus on the rural bill, and we're going to focus on PCHETA this year for that expansion to access. Finally, I want to tell you about this exciting program, and I wish my friend Zinnia Harrison, who I work with, was here because she's the architect of this program. I don't know how many of you have heard of the We Honor Veterans program that NHPCO supports in collaboration with the Veterans Administration. But it is open to members, non-members. There's levels of certification, so you work on building the program. And it's just a great recognition for veterans as they're nearing end of life. We talk about trauma-informed care, and this is a great example of that. We find that a lot of veterans who maybe never talked about their experiences as they're dying find the need to go through that. And then it's also recognition of their service, and there's beautiful ceremonies, pinning ceremonies. If you ever get the chance to participate in that, I would just highly recommend you do so. It's a beautiful thing. So now we want to take the learnings from that program and our we actually have a council that I want to make sure I say them right, the Diversity Advisory Council, that is taking this on as their project. They're going to set up a program based on that same building of certification over time to really help improve equity and access for marginalized populations within hospice. We know it happens, we know it's happening, and we want to do something about it to improve that. So we're very excited about that program. We're going to start with a pilot in fall of 2019, and then we're going to run that for about 9 to 12 months, evaluate it, improve it over time, and then we'll do widespread adoption. And again, it will be open, I'm sure, beyond NHPCO membership for participation. I think that I made it through in the time, and I didn't cough, because I've been the one hacking back there in the back the whole day. I'm so sorry. I really thought I was okay. I'm hopefully haven't infected anyone, but thank you for your time.